Be me, 42, Chief Administrative Officer at Regional Hospital in upstate New York. Salary $210,000 plus benefits. Been in healthcare administration for 17 years. Hospital is called St. Michael's Medical Center, 320 beds, Level 2 Trauma Center. We serve a region of about 400,000 people. Only major hospital within 50 miles. Staff of 1,200, including 180 physicians across all specialties. I handle operations, staffing, department budgets, basically everything non-clinical. Except I do influence clinical decisions through staffing and budget allocation. Been here 3 years, brought in to modernize operations and improve culture. Hospital has reputation for being old school, male-dominated hierarchy. Medical staff is 68% male, 32% female, typical for hospitals in this region. But leadership is worse. Department heads are 11 men, 2 women. Chief of surgery, chief of emergency medicine, chief of cardiology, all men. Most of them have been here 15 plus years, old guard, resistant to change. Hospital CEO is Dr. William Chun, 61, physician turned administrator. He's focused on clinical outcomes, patient safety, financial stability. Doesn't care much about culture or equity, just wants numbers to be good. That's where I come in, to push the culture forward while he handles medicine. When I started, I immediately saw the problems: systemic gender imbalance. Women physicians consistently passed over for leadership positions. Male doctors dominate committees, make all the major decisions. Women are concentrated in soft specialties like pediatrics and family medicine, while men control the prestigious specialties like surgery and cardiology. This is structural inequality. This is what I was hired to fix. First year, I focus on pipeline, hiring more women physicians. Work with recruiters to prioritize female candidates for open positions. Not officially a quota, just enhanced outreach to underrepresented candidates. But in practice, I'm pushing recruiters to find women for every opening. Year 1 results are good. Hired 18 new physicians, 12 are women. That's 67% women. Huge improvement. Board notices and approves. But I'm running into resistance from department chiefs. Chief of Emergency Medicine, Dr. Robert Hayes, 54, comes to my office. The ER attending position. You hired Dr. Sarah Mitchell over Dr. James Park. Dr. Park had 8 years ER experience. Dr. Mitchell has 3 years. Dr. Mitchell is an excellent physician and brings diverse perspective. This isn't about perspective. It's about experience in a Level 2 trauma center. We handle major traumas, car accidents, gunshot wounds. We need experience. I'm defensive immediately. Are you saying Dr. Mitchell isn't qualified? I'm saying Dr. Park was more qualified, and you chose the less experienced candidate. I chose the candidate who best fits our culture and diversity goals. He leaves frustrated. I document his resistance to diversity initiatives. Similar complaints come from other chiefs. I dismiss all of them. They're protecting their territory, uncomfortable with change. Year 2, I get more aggressive, start pushing for leadership changes. Target the department chiefs, the old guard who control everything. Chief of surgery is Dr. Thomas, 58, been here 22 years. Excellent surgeon, low complication rates, respected by staff. But he's a man. He's held the position for 12 years. Time for change. I start documenting minor issues, building a case. He's not responsive enough to patient complaints. He's resistant to new quality improvement initiatives. Doesn't prioritize mentorship of female residents. None of it is serious, but it creates a pattern, a narrative. Approach CEO Dr. Chun with my concerns. Dr. Bradford's leadership style is outdated and problematic. He's been chief of surgery for 12 years. We need fresh perspective. Dr. Chun is skeptical. His surgical outcomes are excellent. His complication rates are among the lowest in the region. But his leadership doesn't reflect our values on equity and inclusion. Show him the numbers. Surgery department is 75% male physicians. That's because general surgery is a male-dominated field nationally. And we're going to perpetuate that by keeping male leadership. I push hard. Eventually, he agrees to explore leadership transition, not firing Dr. Bradford, but suggesting he step down as chief. Offer him senior attending role, same salary, no administrative duties. He's offended. Rightfully so. He's done nothing wrong clinically. You're removing me because you want a woman in the role. We're creating opportunities for underrepresented voices in leadership. I'm being pushed out for political reasons, not performance reasons. He has no choice. Either accept the transition or leave the hospital. He accepts, steps down as chief of surgery, stays as attending. Now, I have to find a replacement. This is my chance. Surgery department has 2 women surgeons, both relatively junior. Dr. Lisa Chun, 38, been here 4 years, competent surgeon, good with patients. Dr. Jennifer Walsh, 42, been here 6 years, also competent, active in committees. Neither has leadership experience, neither has been chief anywhere. But both are women, both are ready for opportunity. Also have 8 male surgeons who are more experienced. Dr. Richard Stone, 48, been here 10 years, trains residents, respected. Dr. Michael Torres, 51, 15 years experience, leads quality improvement. Both would be obvious choices based on experience and qualifications. But both are men. Both perpetuate the existing hierarchy. I make the decision, Dr. Jennifer is new chief of surgery. Announce it in department meeting. The male surgeons are shocked. Dr. Stone speaks up. Jennifer, congratulations, but can I ask the process? How were candidates evaluated? Were we able to apply? I'm ready for this. We conducted a comprehensive review of leadership potential. Dr. Walsh demonstrated the vision and values we're looking for. He's not satisfied. I've been leading resident education for 6 years. I've published 15 papers. I sit on 3 hospital committees. Those are important contributions, but we need diverse leadership. The meeting ends awkwardly. Male surgeons are clearly upset. But I don't care. This is progress. This is what change looks like. Dr. Walsh takes over as chief of surgery. She's nervous, inexperienced. First month goes okay. She's learning, making decisions, growing into role. But then month 2, first major issue. Complex case, 67-year-old man needs emergency coronary bypass surgery. High-risk patient, multiple comorbidities, diabetes, kidney disease. Dr. Bradford, the former chief, is the most experienced cardiac surgeon. He's done hundreds of these procedures, lowest complication rate in the department. Dr. Walsh is on call. She's done maybe 30 bypass surgeries total. Patient arrives, needs immediate surgery. Can't wait for Dr. Bradford's shift. Dr. Walsh performs the surgery. It's technically sound. She does everything right. But patient's condition is more complex than she anticipated. Post-op complications develop. Patient goes into cardiac arrest. Team tries to resuscitate. 45 minutes of CPR. Patient dies. Mortality review is held. Standard procedure for any surgical death. Committee reviews the case. Outcome was likely regardless of surgeon. Patient was high risk. Any surgeon would have struggled. But Dr. Bradford is on the committee. He speaks up. The anastomosis technique used was suboptimal for this patient's anatomy. A more experienced surgeon might have chosen a different approach. Dr. Walsh is defensive. Are you saying I killed the patient? I'm saying experience matters in complex cases like this. Committee notes the feedback, but doesn't fault Dr. Walsh. Patient's family is devastated. They're asking questions. Why wasn't the most experienced surgeon called in for such a complex case? Hospital counsel advises we don't answer, protect ourselves from liability. Family hires attorney, starts asking for credentials for staffing decisions. 3 months later, second incident. Emergency trauma case, car accident victim, 32-year-old woman. Multiple injuries, internal bleeding, needs immediate surgery. Dr. Sarah Mitchell is on call in ER. The physician I hired over Dr. Park. She stabilizes the patient. orders scans, prepares for surgery. But she's not moving fast enough. Patient is deteriorating. Nurse supervisor suggests calling in Dr. Hayes, the ER chief, for consult. Dr. Mitchell refuses. I can handle this. I don't need him hovering. Patient's blood pressure crashes. She's rushed to OR. Surgery takes 6 hours. It's complicated. Patient has massive internal injuries. Dr. Mitchell does her best, but patient dies on the table. Trauma review is held. Dr. Hayes is on the committee. Time to OR was 3 hours from arrival. That's too long for this injury pattern. She was waiting for scan results, following protocol. Protocol for stable patients. This patient was clearly unstable. Blood pressure was 90/60 when she arrived, within normal range. It was dropping. Any experienced ER physician would have recognized it. He pulls up the timeline, shows where delays happened. 45 minutes waiting for court scan. That wasn't necessary. Could have gone straight to OR, might have saved her life. Dr. Mitchell is emotional. Your Monday morning quarterbacking. I'm reviewing a case where a 32-year-old woman died unnecessarily. Committee is split. Some agree with Dr. Hayes, others defend Dr. Mitchell. But patient's family is asking the same questions. Why did it take so long to get to surgery? Was the doctor experienced enough to handle a trauma case? Another attorney, another inquiry, another family devastated. I'm starting to worry, but convince myself these are isolated incidents. Healthcare has bad outcomes sometimes. It's not about the physician's gender. Month 5, third incident. This one is the worst. 72-year-old man comes to ER with chest pain, classic heart attack symptoms. Dr. Emily Rodriguez is on call. She's another of my recent hires. 32 years old, 2 years out of residency, enthusiastic progressive values. She examines the patient, orders EKG. It shows some abnormalities. But she misreads it, doesn't recognize the pattern of acute MI. Sends patient home with probable indigestion and antacids. Patient collapses at home. 6 hours later, massive heart attack, dies. Family brings him back to ER. It's too late. He's pronounced dead. They're asking why he was sent home. Why wasn't he admitted? Autopsy shows clear signs of heart attack that was missed. Medical records are reviewed. EKG is reviewed. The error is obvious. Any experienced ER physician would have caught it, would have admitted him. Dr. Hayes is called to review. He's horrified. This is a textbook STEMI. How did she miss this? The EKG clearly shows ST elevation in leads 2, 3, and AVF. Hospital legal team is panicking. This is clear malpractice. Patient should have been admitted, should have been treated. Instead sent home and died. Family has slam dunk case. Emergency meeting with CEO Dr. Chun, Chief Medical Officer, and me. 3 patient deaths in 5 months, all with questions about physician competency. All 3 physicians are among the ones you pushed us to hire. Dr. Chun is looking at me directly, accusatory. Are you suggesting I hired incompetent physicians? I'm suggesting you prioritize demographics over qualifications. Chief Medical Officer, Dr. Patricia, pulls up hiring records. Dr. Mitchell had 3 years ER experience. The male candidate had 8. Dr. Rodriguez had 2 years experience. The male candidate had 6-inch. In both cases, you advocated strongly for the less experienced candidate. Feel defensive. They were both qualified. They met minimum requirements. Minimum requirements for routine cases, not for complex trauma or cardiac emergencies. Dr. Chun is getting angry. Rare for him, people are dead. 3 patients who might be alive if we'd hired more experienced physicians. You're being reductive. Experience isn't the only factor. In medicine, experience is the primary factor. Everything else is secondary. He pulls up complication data, shows trends over the past year. ER complication rate is up 22% since you changed the hiring approach. Surgical complication rate is up 18% since Dr. Walsh became chief. These aren't coincidences, these are consequences. The legal team jumps in. We have 3 lawsuits, potentially $15 million in liability. All three cases involve physician competency questions. All three physicians were recent hires or promotions that administration pushed for. They're looking at me, blaming me. I'm the common denominator. I was implementing diversity initiatives that the board approved. The board approved diversity goals, not lowering standards. Dr. Chun stands up. I'm requesting an external review of all hiring and promotion decisions to determine if clinical qualifications were compromised. 2 weeks later, external review comes back. It's devastating. Law firm hired to review. They interview staff, review decisions, analyze data. Their report is 87 pages. I'm only given highlights. Pattern of prioritizing demographic characteristics over clinical experience in hiring. Multiple instances where less qualified candidates were selected. Department chiefs consistently overruled by administration on staffing decisions. They interview the rejected candidates, the men who weren't hired. Dr. James Park, the ER physician, passed over for Dr. Mitchell. He's now working at another hospital, doing well, no complications. I was told I wasn't a culture fit, despite having more experience. I've been working in level 2 trauma for 8 years. I knew what I was doing. Report concludes, hospital prioritized appearance of diversity over patient safety. Administrative decisions contributed to increased complications and patient deaths. Board calls emergency meeting. I'm required to attend. They're not happy. They're scared. Liability is existential threat. Board member, who's an attorney, speaks first. These lawsuits could cost us $15 million, potentially more. But worse, we could lose our trauma center designation. State Health Department is investigating after 3 deaths. Another board member, were you instructed to lower standards for diversity? No, I was told to improve diversity. I used my judgment on how. And your judgment led to hiring less experienced physicians who made fatal errors. The patient deaths are my fault. They're saying it explicitly. I hired qualified physicians who had unfortunate outcomes. You hired minimally qualified physicians who were in over their heads. CEO Dr. Chun presents more data, complication trends, outcome metrics. Every category has gotten worse since I changed hiring practices. Patient satisfaction down, readmission rates up, mortality rates up. This isn't coincidence. This is systematic degradation of clinical quality. Board votes. It's unanimous, 9-0. Chief Administrative Officer position is terminated effective immediately for prioritizing non-clinical factors over patient safety in staffing decisions. No severance, terminated for cause, escorted out that afternoon. 3 patients died. Their families are suing. I'm potentially named in the suits. Local news picks it up. Hospital administrator fired after patient deaths. Investigation reveals diversity hiring may have compromised care. Story goes regional, then national. I become the face of diversity gone wrong. Comments are brutal, half attacking me, half defending me. She killed people to push her agenda. This is what happens when politics enters healthcare. Other side, she's being scapegoated for systemic failures. But the patient deaths are real. The families are real. The pain is real. 3 people died who might have lived with more experienced physicians. That's not politics. That's not scapegoating. That's just fact. Spend the next months in legal hell, depositions, discovery investigations. State Health Department investigation concludes hospital violated standards. $2 million fine, 2-year probationary status for trauma center. 3 lawsuits settle, total of $12 million. Hospital insurance covers most. But reputation is destroyed. Patients are going to other hospitals. Revenue drops 18%. Hospital has to cut staff. Programs are eliminated. Dr. Chun retires early. Too much stress. Board wants new leadership. Dr. Walsh steps down as chief of surgery, returns to regular attending. Dr. Bradford is asked to return as chief. He accepts, stabilizes department. Dr. Mitchell and Dr. Rodriguez are let go. Hospital can't keep them. Not because they're women, because families won't consent to their care. I don't want the doctor who killed that patient treating my family. They leave quietly, take positions at smaller hospitals, rural areas, where their limited experience is more appropriate for case complexity. I'm unemployable in healthcare, completely radioactive. Every interview gets to tell us about St. Michael's. Try to spin it. I was implementing board-approved diversity initiatives, and 3 patients died, and you were fired, and the hospital was fined. Can you help us understand your decision-making process? Can't defend it, can't justify it. Decisions speak for themselves. I hired less experienced physicians because they were women. I promoted less experienced surgeon because she was a woman. And patients died, and hospital nearly lost its trauma designation. 1 year after being fired, working at medical supply company. Sales coordinator, $58,000, calling on hospitals to sell equipment. Used to run a hospital, used to make $210,000, used to have authority. Now I'm selling bedpans and calling it a career. Walk into hospitals, see the hierarchy, the structure, the male chiefs. Used to think it was oppression, used to think it needed fixing. Now I see it's just experience, just competence, just people doing their jobs. 2 years later, see article about St. Michael's. Hospital regains full accreditation after quality improvements. Dr. Bradford is quoted, "We refocused on clinical excellence, hiring the most qualified physicians regardless of other factors. They're thriving, patient satisfaction is up, outcomes are improved. They still hire women physicians, still have diversity, but they hire qualified women, experienced women, competent women. Not junior physicians push through because of my agenda." See that Dr. Mitchell is working at small rural hospital. 20-bed facility, low acuity patients, appropriate for her experience level. She's doing well there, good outcomes, no complications. Because the case complexity matches her experience. She wasn't incompetent, she was just inexperienced. And I put her in situations she wasn't ready for. Made her treat traumas she hadn't seen enough of. And a 32-year-old woman died because I prioritized gender over experience. That death is on me, on my decisions, on my priorities. 3 years later, 45 years old, still selling medical supplies. Make $65,000 now. Got a small raise, still nowhere near admin level. Still in healthcare, but from the outside, selling to the people who used to report to me. Sometimes I see former colleagues. They're polite but distant. Everyone knows what happened. Everyone knows about the deaths. Nobody wants to be associated with the administrator who prioritized diversity over safety. Think about those 3 families every day. 67-year-old man who needed the experienced surgeon. 32-year-old woman who needed faster trauma care. 72-year-old man who needed experienced ER physician to read EKG. They're dead. Their families are devastated. Their potential is gone. And I contributed to that by hiring less experienced physicians. Not because I'm evil, not because I wanted people to die, but because I prioritized my ideology over clinical reality. Because I thought diversity was more important than experience. Because I thought good intentions would overcome skill gaps. They don't. In medicine, experience matters, skills matter. Lives depend on physicians making the right call under pressure. And junior physicians, no matter their gender, aren't ready for that yet. That's not sexism. That's just medicine. That's just reality. I forgot that. I ignored that. I pushed through anyway. And people died, and hospital nearly collapsed, and my career ended. Now I'm here, 45, selling bedpans for $65,000. Former chief administrative officer who killed her career and contributed to killing 3 patients by prioritizing demographics over qualifications. That's my legacy. That's what Google says about me. Administrator fired after patient deaths linked to diversity hiring. That's the first result. That's what I'm known for. Not for my 17 years in healthcare, not for my other work. Just for the 3 people who died on my watch. Because I hired the wrong physicians for the wrong reasons. And learned too late that in medicine, You can't prioritize anything over competence. Not diversity, not equity, not good intentions. Just competence, just experience, just skill. Because lives depend on it. 3 lives that I help take away. By forgetting that fundamental truth. That's what I live with now. Every day, selling medical equipment. Walking into hospitals that I used to run. Seeing the structure that I used to think was oppression. Now understanding it's just experience-based hierarchy. Where the most skilled rise to leadership. Where patient safety comes before politics. Where lives matter more than ideology. That's what I should have known. That's what cost me everything. And cost 3 people their lives. Because I didn't know it. Until it was too late. And they were dead. And I was fired. And my career was over. All because I thought diversity mattered more than keeping people alive. I was wrong. Catastrophically wrong. And 3 families will never forgive me. And I'll never forgive myself for forgetting that. In healthcare, nothing matters more than competence. Nothing.